Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend Colin. The world of technology and healthcare, ever-changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news, meshed together in new ways which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. And today we're going to be talking about the World Cup of Health IT. And be sure to follow the show on social media at the hashtag HITSM and on LinkedIn under John Lynn, Lynn, and Colin Hung, HUNG. Plus, check out our 20 years of health IT content at healthcareittoday.com. Any surprises in the World Cup for you? Have you watched a lot, or are you kind of a casual score watcher?
No, I mean, I'm not a huge football fan or soccer fan, but the World Cup is the one time I do kind of take an interest in it, just to see some of the classic players, of course, like Messi, and see what Ronaldo is doing.
It's not because Canada finally won an international competition.
Yeah, I know.
Yes, they lost the hockey. Oh,
yeah.
You're now a soccer nation. Yeah.
Yeah. No, we made it to the round of 16. I mean, that's amazing. So we're pretty happy. The country's pretty happy. And yeah, hosting two of the games here in Canada, in Toronto and Vancouver, it's kind of special.
Yeah, but they deserve a red card for not having all the Canadian games in Canada. Like, come on, that didn't take a rocket scientist to figure out.
That should have been the case, but we did come in second in the group, so that's why we didn't get home field advantage. That's why we have to play in Houston. So,
still done.
But anyway, it's fun. It's been fun to see all the different countries and to see how popular it actually, and all the fans from all over the world coming into the various places. Right, it's been pretty fun to watch all of the Scots, take over Boston, and to see all the Norwegians take over the various other cities. It's been pretty fun.
Yeah, I was in Kansas City, I think 2 days before like the full festivities and downtown and everything. It was all dressed up, ready to go. And it was interesting to see, although, what the most interesting thing was, I guess so many other countries don't tip. So all the restaurants in that area forced a 20% tip. And I don't know what this says about me, but I'm so habitual. I just start writing the tip. And then I'm like, oh crap, they already added it. Dang it. What am I like? Now I tip double. So it's like they screwed out us that try to be generous.
Yeah, well, this is gonna be fun, John. So let's start with this one. In soccer or football, depending on which side of the Atlantic you're from, a player gets a yellow card when they commit a reckless foul or waste time or show unsportsmanlike behavior. So, in your opinion, John, who deserves a yellow card in healthcare right now?
Yeah, there's two that came to my mind. And by the way, someone said if the U.S. wins the World Cup, it should be called soccer for the next 4 years or something. Anyway, two of them came to mind to me, and they're both financial ones. And I forget the actual term for the one, but there's a term now that I think came out of the Surprise Billing Act that allowed provider organizations to essentially, if they get denied a claim, they can appeal it to this board. And if they appeal it to the board, they could maybe get paid for it, for what they were doing. But what they found was that the appeals board has been completely provider friendly. And so not only do they get paid what they appealed, they'll often get paid 2 to 3 times the amount that the original claim was. And so people are, as you can imagine, abusing this and just appealing everything, knowing that they're going to win. And it's become very favorable to the providers. What's interesting is I'm not sure how long it's going to last. So that's probably why it gets a yellow card. The one that's more disturbing, and maybe I should save it for the red card, but I'll give it a yellow card for now and I give them a yellow card as well in the previous instance and the one that I'm about to explain, because, hey, this is what the laws state. Like people are doing what they can within the laws and reimbursement, rules that are out there. The other one is where they buy up a medical practice, they slap on that it's now a hospital, and then they pay them 3 times as much Medicare does because it's a hospital venue rather than an ambulatory clinic, or it's it's a hospital instead of a surgery center or whatever it was, right? Like, so to me, that deserves a yellow card because I hate that kind of crap. I mean, hey, I get it from a business perspective. You should maximize your reimbursement every way you can. But here's, and maybe the red card goes, we'll hit the red card in a minute, but maybe that goes to the government for not closing that loophole a long time ago, because we've known about it for a while, and why it hasn't been closed up, I don't understand. Maybe it's hard to close because, if it was a true hospital site, they do need the extra reimbursement. But the abuse, I mean, come on, it's pretty clear that was a doctor that was seeing a patient, and now you're going to pay hospital rates. That anyway, give them the yellow.
I like that. We should have had those props, John. No,
Yeah,
now I'm thinking about it. We should have had yellow cards. For me, I would give a yellow card, not because a lot of them are doing something wrong, but I give a yellow card because I think they're wasting a lot of time. And that is actually a lot of AI companies that are entering the healthcare market. Now, I say that because AI is the hot new thing. Obviously, one of the applications of it in healthcare, healthcare is a great industry where AI can be very helpful. But there have been a lot of companies that have entered the healthcare market who really don't understand healthcare. And I think they're wasting a lot of provider organizations' time and a lot of IT resources because people get enamored with it. They're like, oh, I want to use this. I want to try this. And not necessarily for a clinical application, but just, hey, I want to use this for developing, or I want to use this for my HR. I want to use this for those types. I want to use this on my website. And I think the amount of time wasted doing the due diligence on it and these companies not really understanding healthcare, I think they deserve a yellow card. Like, you got to make it really clear and transparent. How's your AI trained? Where's it trained? How do you protect the privacy of the information going through it? A lot of companies I see that are entering the space don't have that information, and it just wastes so much time.
Yeah, no, that is a good one. I mean, the reality is there's so many yellow cards in healthcare, right? I mean, I like to call it perverse incentives in the past, right? There's so many perverse incentives for them to, how they get paid is different than keeping you well, or how they get paid is different than keeping you out of the hospital, right? So I think those are some of the challenges that definitely deserve yellow cards. And it's usually not an individual trying to do evil, right? In fact, most of the time, the individuals want to care for the patient. They want to do what's best for the patient. But so many of the systems that we have set up are screwed up that there's not that alignment of financial and health priorities.
Well, let's move on to the next one, since you've already brought it up, John. That, of course, so a player in soccer gets a red card when they commit a serious foul, either against another player or against an official. So who deserves a red card, meaning they should be kicked out of the game in healthcare right now?
Oh man, this one's a tough one because, I think the pharma industry and maybe the pharma lobbyists in particular, they deserve a red card. The way that they're profiting on so many things and the way that they're structuring their pricing, it's gotten out of hand. I don't know the fix, right? Like that's the problem, and it's not an easy fix. But I'd start with like, hey, no more pharma lobbying. Like, let's start there and imagine how that would change, how people approach it. They actually have to provide value, not just lobbying efforts. And I think the FDA and different things related to that have been abused in ways that are problematic and costing us a lot. And so anyway, the whole pharma kind of subsystem, not the scientists doing the work and trying to evaluate it, they're usually pretty good, and they've created some life-saving drugs that have done some amazing things, but it's definitely profits over patients in a lot of those organizations. I think that's problematic. The other one that I think is, probably Mark Cuban's favorite, whipping boy, but the PBMs, like, any layer that adds an extra layer of bureaucracy, and the way that they're just taking in cash hand over fist should be a sign to us that something's wrong, right? Like, what service are they really providing that they deserve to be paid? I don't really know the answer to that, right? Like, and that so that definitely deserves a red card. The middleman and the pricing strategy I'll steal from Mark Cuban again. He's just like, anytime that they try to make complexity to be able to avoid you understanding how much something really costs and how much it's going to get paid, probably means there's something not so great happening underneath.
Yeah, it's hard to argue with you, right? I mean, especially when you consider the example of insulin not too long ago, right? And how that price just was skyrocketed by a handful of companies doing not so great things, right? And how that shouldn't be as expensive as it is. But there's so many middlemen, there's so many other companies, each profiting along the way, that it ends up, of course, pricing a lot of patients who need it out of the market.
Which is annoying, because if you're a diabetic, you're not going to not take it, right?
Yeah.
Like, that is not an option.
Exactly right. And I know the pharma companies are trying to do the right thing with some of these financial assistance programs, but that to me is a Band-Aid on a broken system. As you pointed out, there's just too many steps, too many perverse incentives, too much ingrained lobbying, too much ingrained infrastructure. It's going to take a big change and a lot of courage, frankly, to change that industry. I'm hoping it will, but definitely I agree with you. It deserves a red card. For me, the red card is an easy target. But it's anybody that's committing fraud, right? I mean, that's an easy one for me. You got to get rid of those people. And, it is something that every administration in the US and every government across the world has been trying to ferret out. It's trying to eliminate fraud. And we have bad apples. And we just had that one example of a person who was milking, almost $1 billion out of the Medicare, Medicaid system and escaped. I mean, they deserve a red card, right? Like, let's get rid of them. Let's implement technologies to help detect it faster, earlier. Frankly, we should never have been paying for those types of things. I think there was genetic testing for no reason and wasn't even carried out. We need to get rid of those people, because that's an easy target. I think that's the one target everyone agrees, yeah, we need to get rid of that. That would help save the medical industry a lot of money.
See, and that's the red card I wanted to give, was to the government legislation and the people who pass the legislation, like a fraud thing, or even other things like information blocking, HIPAA violations, et cetera, right? Where you pass it, but you don't fund it to actually enforce what's happening, right? Like, you would think that there would be enough technology, know-how, expertise, et cetera, to stop that $1 billion of fraud, right? Like, I mean, that's embarrassing, the people that are behind that. And I've met a few of them, and admittedly, these people are good at their fraud, right? Like, it's challenging to understand because it looks so legitimate. Just like hackers would do in security, they're hard to fight because they're good at what they do. And so, I have some sympathy, but there are so many mandates, especially on the health IT side, information blocking, right? But there's no financial investment to actually enforce it. They'll do a couple things here or there to make a show, but there's certainly not the investment to actually enforce what the law is. And if you don't have the money to enforce it, is it really a law?
Hey, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and Colin Hung. Today, we're talking about the World Cup of Health IT. All right, John, as you know, the World Cup is definitely a big international event. What are some of the international health IT developments that have caught your attention recently?
I think for me, it's been fun to watch all the different nations adopt EHRs because they didn't have the stimulus, so they're a little behind. Some of them, right? Some organizations were way ahead and they've been through the whole cycle. But, seeing EHRs just being implemented and how internationally it can be done in a very different manner. It can be more about patient care as opposed to billing. And so that's been eye-opening, whether that was when I was in Dubai or whether, hearing about Spain and how they're implementing it, even full countries, right? I think Meditech has an implementation in, I think it's Zimbabwe, if I remember right, one of those African countries, and adopted all Epic across the entire country, which was an interesting approach, right? When you have that. But I will say the African countries have stood out to me, and even some of the underdeveloped ones in India and some other countries like that. And I love them because they're like havens for innovation. And the best example I could use was an eye test where you're like, oh, but that's not FDA cleared and that's not blah, blah, blah. We can't use that in the US. And they're like, well, if I'm in an African village, do you think I care about the FDA clearance of the thing? Right? You're like, well, if my other alternative is just be blind, guess what? That not FDA cleared test that's pretty good at doing it and understanding it, like that's good enough. And so I think we've seen a lot of those things happen where it's like, hey, this isn't going to, we haven't got FDA clearance yet, but let's just go start using it in these developed worlds where that care, that eye test, the eye exam, the dermatology stuff, a lot of vision stuff with the cameras, right? Where it's looking at different diseases or different, sicknesses, those are really interesting. So I've seen a wide variety of those, especially in Africa and other kind of, underdeveloped areas.
Yeah, no, I agree with you. I mean, not to say that a lack of regulation spurs innovation. I don't think we're saying that, but definitely in those areas, good enough, the bar is much lower. And so, yeah, I mean, because of course, in the Western nations, in the US, Canada, Singapore, other places, we have a high bar. Like we've got the technology to do a really good glaucoma detection, right? But when you're in a country where it doesn't have that infrastructure, all you have maybe is a cell phone. And so, yeah, a cell phone versus an actual device, no contest. That device is going to be much better, but you can't move that around. It costs so much. It needs specialized training versus let me take a picture of your eye with the bright light of the flashlight. And that's, 50% of the time it'll get it right. That's better than zero. So I agree with you. That's kind of some interesting things. I too have seen some of those innovations come across, or at least I've heard about them. I had recently had a chance to go to the eHealth 26 conference, which is Canada's sort of version of HIMSS, and got an earful about the interoperability initiatives that Canada is doing through CaiHi and other people, and how they're working with actually the Australian counterparts to make sure that the two countries are learning from each other and not making the same mistakes. There was a lot of talk about CACDI, the Canadian version of CDI, and then the Australian version of CDI and HL7 standards. And so they're basically trying to make sure that the countries can be compatible. Not that we're going to be interoperable, but are compatible. They're following the same rules. So I think that was pretty interesting. I know that the NHS is doing a ton of work of trying to get interoperable and do a lot with AI governance. That was another big thing, that a lot of these countries are implementing AI regulations. And part of it is the AI use in healthcare, what it can and cannot be used for. So I found that very interesting, that that's starting to rear its head around legislation. So I'm keeping my eye on that to see who and what is going to be the restrictions. For example, the ban they put on using AI for people under 16, right? In a lot of countries, unfortunately has included the use of AI in healthcare for people under 16 inadvertently. And so now they're having to go back and fix that and go, well, wait a minute, well, we didn't mean that. Or we didn't, our social media, we didn't, so anyways, kind of interesting that this is all happening. So those are some of the developments I'm keeping my eye on.
Yeah, I mean, it's interesting you mentioned interoperability. I would have thought, and maybe you can enlighten me why this doesn't happen, that in Canada, they provide universal health care, and so it's happening. Why can't they just say, hey, you have to be interoperable and you have to share? And why doesn't that solve the problem? And maybe there's something to learn, right? It's not about the mandate, and it's maybe about something else more important. Because, we've seen like Meditech has a big presence in Canada as well, and they've had real success with, I think it's called Traverse Exchange, which I think is powered by Health Gorilla, if I remember. And they're having great success, and I think they're porting that to other countries as well. I know they do a lot of work in Ireland and South Africa as well. It's like, it seems like if you mandate interoperability, shouldn't that just happen? I agree with you. You should use standards, HL7 Phi or whatever, right? But why doesn't it happen?
That's a whole episode on its own, John. But to be blunt, it was never part of the policy. That basically was it. They never thought about this when they put together the health system. They baked in facts as a communication protocol, but they never baked in that the records must be interoperable. And then all of a sudden, because they couldn't imagine a world that had multiple EHRs, right? So the fact that in Canada, we have Meditech, we have Oracle now, we have Epic, we have some homegrown systems. Each of them, although they were supposed to be compatible, they ended up not being compatible. So you can't share. It's very difficult to share records in Canada. However, that's one of the developments that's happening is now we've enacted our own version of info blocking and there's a new bill on the docket that's going to enforce interoperability. To do exactly what you said. In order to operate in Canada, you have to be able to interoperate.
Yeah, it's fascinating to think about it. And I guess it kind of makes sense. Maybe there's one world where they're like, why wouldn't they share? Like, why do I need to prescribe this? You should share. Like, there's no risk to you to share. And it's the best thing for the patient. But yeah, anyway, it's fascinating. But there are a lot of cool things, right? I mean, there's a lot of initiatives in Dubai and UAE, even Saudi Arabia. When you look at some of the healthcare events that they're doing and the ways that they're investing in AI and really similar to what you were describing, like they want to care for their citizens in a way that's really powerful, and they're making those investments there. What's funny is that as much as different in international, it's still the same when it comes to doctors, whether they want to accept it or not, whether they want the clinical decision support or not, whether they adopt the latest technology or not. Like those things, the arrogance of certain groups versus others and the competing, like that is the same no matter where you go.
Yeah, and that's funny. Like when you talk about that, that's the great equalizer. We may have different structures and one payer versus multiple payers and different kinds of systems and certifications. But at the end of the day, we still have doctors complaining they spend way too much time documenting. And we have nurses who complain that there's not enough of them and they get overworked. And those problems are very, very universal. Yeah. So, John, one of the things that as a regular soccer fan, but the one thing that I think most people will notice watching the World Cup is that the games are very close. The sides are very evenly matched. I mean, for a long time, it's 0-0 right, for most of the game. So it's hard to pick a winner. So I'm going to challenge you to pick a winner of this fictitious match between two health IT projects. So on one side, we have a health IT project around around cybersecurity. And on the other side, we have a health IT project around clinical efficiency and burnout. So if we pit them in a match, who should win, John?
Don't you love impossible questions, right? Both of them, of course, right? There are ties in soccer too, but I guess this is a playoff round, and
that's right.
We have to go to penalty kicks and see who wins, right? But I mean, you're highlighting why I think it's so hard to be a CIO leader right now. And not just that, but that you're being asked, hey, you're only allowed to do cybersecurity or this clinical efficiency burnout project. And by the way, your budget's being cut too, right? Like that's the environment we're in. I think what you have to do is, I think, the reality is you have to kind of look at your history. So I don't think there's any one answer for an organization. If you haven't, invested in cybersecurity, then that might win out because you don't want to burn your users and lose their trust if you get a breach, and then it's going to cost you a lot more money later. But if you've done a pretty decent job of investing in that in the past, then, I think the clinical efficiency and burnout could win out, in that regard. What's interesting, though, is if you go to the board, that's the other thing that influences it. The board priorities are going to reflect and impact this more than anything else. If they put cybersecurity as a priority and burnout's not a priority, guess what's going to be purchased? The cybersecurity project, because that aligns with the priorities of the organization. But if burnout is a problem and workforce retention and all of that, then guess what? If you don't have workforce, you don't need cybersecurity. So you better make sure that you retain that workforce so that they can take care of it, and you can do the cybersecurity later. And it's a bit of a unfair question, right? Because you can do both to some degree, at least, and mitigate the loss of one, while investing in the other.
Sure. I mean, you're right. I mean, the answer is both should win, but in this fictitious match, I'm going to go out on a limb and say, on paper, cybersecurity should win. But your heart is probably with the clinical efficiency and burnout, right? Because that affects people. Not that the other one doesn't, but that affects people that you work with. It affects the clinicians. It affects the administrative staff. So anything you can do to implement technologies to help make that easier, it's a win. And it's a good feeling. And yes, you're right. We have a burnout problem. We have a retention problem. And those are good things to solve. It tugs at the heartstrings, right? They're the underdog that you want to cheer for. But on paper, and to me, cybersecurity should win out because this is a threat. Like you could be down for multiple days. It looks terrible when you do have a breach. Even if you don't have a breach, just, being caught with a system that's not available to you, even if it's a minor one, is horribly inconvenient and could threaten all the other things that you're doing in terms of delivering good outcomes to your patients, right? We've heard the horror stories of hospitals having to go revert back to paper because they won't pay the ransoms, or when one subsystem is just down because they didn't do the patch update. And forget about whether it's a cyber attack or not, just this update didn't happen properly and the system is down for a week. That's a horrible situation to be in. So my take is that the cybersecurity project should win out in a head-to-head match.
That's interesting because I agree with you that, like on paper, your mind says cybersecurity, but your heart says efficiency and burnout. And my evaluation after talking to so many CIO leaders, especially on the CIO podcast and stuff, is the one that's going to win out is actually probably the efficiency and burnout. Because let's say you're really successful in your cybersecurity project. Guess what's going to happen? Nothing. You're not going to get the award. You're not going to be praised at the hospital's annual meeting. You're not going to hit the foundation meeting saying, look at what we did. But if you address the clinician efficiency, then you show that you were able to care for more patients and you were able to provide higher quality care, and that you had less fallout. Your retention was high of doctors because you addressed the burnout. Those are all tangible things that are going to get you the kudos and you're getting another year as CIO because you chose to do this. Whereas I don't know any CIO that's been retained for an extra year because a cybersecurity incident didn't happen. It probably should, right? Like we probably should maybe we need to come up with a Healthcare IT Today award that says, hey, congratulations, you've gone 4 years without a cybersecurity incident, right? Like maybe we should create some praise around that, but it doesn't happen right now. So I actually think the heart probably wins, which, for a World Cup, sometimes, the difference between those games is who has the heart to push through the pain and grind through to get there that one step quicker. I mean, it's a game of inches when you look at it, right? And if you put up that little extra effort, that little bit of more heart than the other person, you get to the ball and it goes in. That seems right. So, yeah, I agree with you on paper, cybersecurity, but, I know you, Colin. I've been in Vegas with you enough to know you're not a gambler. So it makes sense why you chose that too.
Well, it's been fun, John. And let's, by the time this airs, the World Cup should be decided. But hopefully it's a country that somebody out there listening to this was rooting for.
Yeah,
but hey, yeah, it would be amazing if it was Canada versus the US, wouldn't it? That'd be fun. Rematch of the hockey. Anyways, thank you to all of you who tuned into this episode of Healthcare IT Today. You can find out more details about our show by checking out the programs page on healthcarenowradio.com. And please share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm Colin Hung, along with my friend and Health IT collaborator, John Lynn. Thanks for listening and have a great week.